Okay, so thank you guys for joining us today on the podcast, Mike and Sam. I think it's good that you guys introduce yourselves in terms of what you do, your occupation, the company as a whole. I think if I do it, I might get a few bits wrong. It's a little bit too intelligent for me.
No worries.
All right, so I'm Mike Kosis. I'm the founder of Balance My Hormones, director and also case manager for patients who have questions about TRT, and we help manage and coordinate those patients in a very comprehensive program, TRT being testosterone replacement therapy. So we've set up a nice service for patients that aren't getting the care that they need through the NHS. They can come to our service and we could put them through the proper medical care for testosterone deficiency.
Yeah, so I'm Sam, and I am the operations director for Balance My Hormones. We do the sort of medical case managing, coaching along the way with clients as well. But like as Mike said, perfect summary of what we do there. We sort of put it all together for people, HRT, TRT, and just make the experience sort of supported and coordinated all the way through, which seems to, it's a certain area that sort of requires it from a journey that someone goes through. It seems to be key. So yeah, so that's what we do.
Excellent. Thank you, guys. I think a good place to start, and I know my subscribers love this sort of thing, especially on my YouTube, is testosterone and the state of testosterone at the moment for men. Me and Mike spoke about this earlier in the week or last week when we had a discussion that men's testosterone levels are reported to be at an all-time low. I believe the statistic was a third of what their granddads were. I guess it was around about the war period. What do you think's going on? Why do you think they're so low, and how much of a pandemic is it? And how bad is it going to get, really?
Yeah, I can start with this one, Sam.
Yeah.
So, yeah, I mean, with the low testosterone, there have also been reports of lower fertility. So I think the two go hand in hand. And if you just look at our lives since the Second World War and, the amount of pollution and the stress in our lives. So it's the lifestyle, how busy people are, not as much time with friends and family to kind of relax and unwind, not to mention the lack of, walking as much or physical activity. And then even when you are outdoors, outside in large cities, and then in our cities and towns, especially in the UK, where, the most dense in all of Europe, and people are in very congested small places with lots of diesel fumes that were brought about, I think, in the late 90s. Everyone switched from petrol to diesel, and that's full of pollutants, not to mention what's being polluted in the water, as well as in the foods that we eat. So, and lots of them are related to the estrogen chemical disruptors, or the endocrine disruptors.
There's a really good book, isn't there? There's, I think it's called Estrogeneration, picture of a tree on the front. I think it's by Dr. Anthony J. That's a really good book if you want, because you hear like, there's chemicals in the environment and there's things that may be disrupting our hormones. But that book's he's researched them, he's looked at the evidence, he's even got sort of what certain countries allow as an acceptable sort of level of these things. So they're allowed to be in our shampoos and shower gels, things like that, and in our water and food supplies, but at certain levels, so that they know they're already present. So that's a really good book for, summarizing, what Mike said about those sort of endocrine disrupting chemicals. So that's definitely one thing, you can actually see the evidence of as well. It's things like in your shampoo and shower gel and personal hygiene products. It's pretty much like innocent until proven guilty. So they can sort of put in quite a number of different chemicals until someone goes, that's not allowed because that's an endocrine disruptor at that certain level. They go, okay, I'll change it. So there's the easy ways around it in that sort of, area. Moisturizers, shower gels, shampoo. So definitely that blue light as well. I'm not sure whether Mike said that, but blue light and disruption of the circadian rhythms and how much we're exposed to as well.
Yeah, as well as certain chemicals in our sunscreens, though it's never really sunny enough to always warrant the sunscreens. But, on holiday, or even lotions, body lotions. And, people that think, well, it's just topical, it doesn't get into the skin. But we've seen with our own clinic that, testosterone creams depending on the formulation, doesn't matter which penetrating formulation it uses, the testosterone can still get through the skin. Well, that's one hormone, but there are other hormones that may be even more potent, like the endocrine disrupting, estrogen mimicking hormones that do disrupt the rest of your body and get through the skin. So, these may be some of the reasons compounded over the years, causing the decline in men's both fertility and testosterone levels.
Yeah, I also think that potentially there's maybe just more of an awareness. Don't know whether you guys agree or not, but it's that maybe more people are being tested when they present with like mental health symptoms, for example, anxiety, depression. Was it for a long period of time that it was just managed differently, given certain other drugs, certain avenues of treatment, and now it's more recognized as something that should be tested for. So maybe we're uncovering just more younger men. It's really common in the UK. If when I first asked to get my hormones checked, I had facial hair and they said, "You've got enough testosterone. I'm not doing a blood test for you." And they sent me away, with all of my symptoms. And if that's been happening, and that was, in the last sort of decade. So, 30, 40 years, I don't know, maybe people, it's just not been picked up on or even recognized potentially. Women's HRT for menopause, obviously it's in their life, it's quite a big medical episode, right? Because they go from, it's very recognized, all the symptoms come on very quickly. So it's been recognized as an issue that women have over the years. But men, you rarely sort of experience that same, okay, all my hormones suddenly drop, unless maybe you lose your testicles or injury or something like that, or head trauma or something. It's a gradual sort of slow steal. So it's sort of men sort of wither away and they accept things as like depression, I'm getting old, fatigue, I'm just getting old, sexual dysfunction, it's just because I'm old. I do think if it happened like women, where we suddenly hit the age of 40 whatever onwards roughly, and suddenly they all accumulated at once and just hit us like a train, I think maybe it would be a bit more recognized potentially.
In terms of fluoride-free toothpaste, hygiene products, etc., are you guys using all of them? Are you using the natural versions, etc.?
Well, not anymore, because I'm on thyroid hormone. So at this point, the fluoride was going to interrupt the iodine production. So no, I don't remove those. I had for a while had gone through that phase where I was, but since I'm basically replacing thyroid hormone, or the doctor's replacing the thyroid hormone, there's really no need to trial that. But that, I don't think that has as great of an impact on testosterone levels. I'm not sure if Sam, compared to some of the more the other endocrine disrupting hormones that have a direct impact on the low testosterone.
I think it obviously, through affecting the thyroid negatively, can affect other hormones like testosterone. But I just take iodine. I think it's because they compete. Like there was obviously bromide, fluoride, iodide, and that sort of group of chemicals. We apparently, and I think I'm parroting someone else here, but I thought it was a good description, that we used to get like bromide in our bread. We've got chlorine obviously in the water, fluoride toothpaste, so we need to have iodide or in some description to actually compete against those other chemicals basically in the body. So we needed those for health. So I just tried. I take iodine. I'm a thyroid patient as well. But I still think it's a sort of a key nutrient. So I just make sure I actually have a lower fluoride toothpaste, but I don't think I did it on purpose. I think it just ended up in my bathroom. So I could say that I do, but it wasn't on purpose. So yeah, I think that's the thing about it is we get plenty of, I think what it is you need iodine obviously for your thyroid hormones. And we were getting plenty of chlorine from water, fluoride, water, toothpaste, and we were getting bromide and stuff from bread, not getting enough iodine to keep us healthy. So that's why iodine supplementation is sort of key, and some doctors will suggest that.
What sort of percentage of men do you think are suffering from this, or maybe living day to day? They've got symptoms, but they just kind of associate it as being normal, because, well, to be honest, everybody's kind of got these symptoms right now.
Yeah, I thought the original statistics were about 5% of men, possibly, but it seems like there are more people than that are suffering from testosterone deficiency, because they've changed the definition. For the countries that use insurance-based healthcare systems, they'll lower the level, the threshold for where you get treated. For our NHS, they've really lowered it. You have to be practically dead to get on testosterone treatment through the NHS. So I guess it depends on what you define as where does testosterone deficiency start. Some of the clinicians, I hate to say endocrinologists, because we've got feelings about endocrinologists and treating testosterone, but they'll say, well, it's hypogonadism. And only true hypogonadism is that in which it's defined in this very narrow range, and it's either primary or secondary. And then there's a greater body of evidence that's looking at testosterone deficiency as the title to describe this lack of testosterone in the male population. Some people will go so far as calling it testosterone optimization. How do you optimize one's testosterone from just a normal level to an optimal level? And that gets into another area. But depending where you define it, that would be the percentage of the population that suffers from it. But recent guidelines like the ISSM, not the ISSM, it's the IASSM, the Aging Society for Males, describe that you have to look at a combination of levels or guidance, but it doesn't tell you if you were high in your youth and now you fall in that degree, that rate of fall from having a higher level to maybe you fall into the average range that's defined by the NHS. That's not fine for that person, that individual. That person's still suffering, has all the symptoms. So you really have to look at the symptoms that person's suffering from. You may also have to look at the amount of free testosterone due to binding hormone, and to really put a picture together. And you may need to go as far as genetic testing to look at the certain CAG repeats in their androgen receptor.
Yeah, because there isn't a level of testosterone that is proven that a man, when they reach or if they're coming down from a certain level, it's here that men will start getting symptoms of testosterone. And that's where guidelines that were made up for doctors, if they come across a patient that they think may need this sort of treatment, right? They look at the guidelines and they go, right, well, I can have a good fair crack at either providing this treatment or referring them on based on the guidelines. They have become rules, and particularly in places like the NHS where there's absolutely a cost implication that needs to be controlled. Things like even like women's HRT, needing to only be on it for 5 years and that's all you're allowed. There's not strong evidence to say women can only get benefit from hormone therapies for 5 years and then it stops. That was based on cost versus efficacy. So those guidelines in the NHS that the NHS use, for example, but are there's certain ones worldwide, have been taken up as rules. But there isn't a level of testosterone that a man says, okay, I'm now here, and suddenly it's dropped below. Now I start getting symptoms. It could, like Mike said, if you're sitting, maybe you're someone who's sitting quite high, naturally for 30, 40 years. And then suddenly you have that, and your levels may be at a level where somebody was cruising along, happily symptom-free for all of their life. And then someone compares that to a laboratory reference range, which is basically just samples from a laboratory. They do 95% of, basically. It's a sample from the test that they do in the laboratory. And then they say, oh, you're here, you're normal. That means you can't be suffering from low testosterone symptoms because you're in our range in comparison to the samples from the laboratory. So that's where Mike was saying, like, symptom presentation is huge. It can direct you down that path, and then you can get blood tests, but you ultimately, need to be assessed by the doctor. The same thing goes for thyroid. Before there were accurate thyroid blood tests, I think it's almost a century now that they've been using thyroid hormone in patients. They didn't have blood testing. They based it on your symptoms. Sometimes they did a physical examination if you were extremely underactive. And then they would try you on the hormone. And if you got better, that was a successful treatment and you needed it. And if you didn't, you'd stop it, basically. So in places like America, you very much can, whatever blood levels you've got, if you've got a certain level in the blood, but you've got symptoms, lots of doctors will just try you on TRT to optimize those levels. And that's where Mike said that the testosterone optimization therapy sort of phrase has gone from TRT to TOT instead of replacement is optimization. And then you often can get treated, but it's a little bit of a different situation in the UK and Europe with sort of what doctors can do with the sort of regulation that they've got. But it is, to answer the question of how many, it's hard to say because I suppose it could be multifactorial as well. You've got hormones in there as well, but I think TRT and HRT, or the thyroid treatment, hormone replacement, is definitely, if you're experiencing any of the symptoms, which can be higher anxiety, lower mood, fatigue, poor sleep, sexual dysfunction, that could just be lower libido, that could be erectile dysfunction. It doesn't have to be all of them to tick all the boxes. If you're experiencing any of those, TRT or HRT or hormones should be a box that needs to be ticked off and checked in your path of figuring out what is wrong, if that makes sense.
That does make sense. That's actually blown my mind because I've always been told that it's between this range and this range is healthy. And the only thing I've ever known, I didn't realize until the other day when Mike said that there was a British range as well. I've always looked at it as, is it nanograms per deciliter, the American measurement? And I remember, I think the top end they said was around about 800, where it becomes a little bit too high. And my dad, around about, I guess it's probably 4 years ago now, he managed to get stage 4 prostate cancer. And he went to the doctor and they said that I'd literally just read a book on somebody Montgomery, can't remember his name now, but testosterone and how when it gets lower, it's linked to increase in prostate cancer risk or getting prostate cancer. So I just read that, funnily enough, and then he gets prostate cancer. So then I sit down with the doctor. And he said, okay, I want to explain it to you too, with your dad here. His testosterone is around about 780. And I think they already had him on estrogen increase in tablets or testosterone decline in tablets. So his testosterone must have been a lot higher than that naturally anyway. So I would have expected it with those tablets to be around about 300-400, but his was already really high. Now, I said to the doctor, surely if his testosterone was always high, probably closer to 900 to 1,000 if you've already brought it down, and he was a healthy man when he was younger. Now that it's dropped and he's got ill, and I've read this book, should we be lowering it anymore? And he kept persisting, saying that we need to lower his testosterone even more in order to cure it. But as you get older and your testosterone drops, your immune system becomes worse, you get more illnesses, more injuries, whatever it might be. What's the kind of thought process on that from your end? Were the doctors right, or is the medical kind of industry slightly behind once again?
Well, I think that was it Morgenthaler was the paper that you wrote.
Abraham Morgenthaler, maybe.
It could have been.
Yeah, I think he's one of the authors of the IASS. So the thing that when we talk about 700 nanograms per deciliter, it's referring to the total testosterone, but you can still be deficient in testosterone if you have high levels of SHBG. And that, I've seen that in other people, in older men who have a really good total testosterone, like, yeah, well done, it's really good. But then if you look a bit deeper and there's a low free testosterone, usually as a result of a high SHBG level, then they actually are low. They're deficient despite how high that total is. And so because the body's not getting enough to the cells that it needs it, because it's all bound up to this protein. So that would be the one thing to consider. And the other is, that study came out and has said that there is a linkage between testosterone and prostate cancer. And the linkage is low testosterone puts a man at greater risk of a malignant type of prostate cancer. And in fact, the low levels all those years for many men may mask a more malignant form. So, you can be cruising along with very low PSA because the lower testosterone may reflect in a lower PSA, thinking everything's fine, only to eventually get symptoms. And then by that time, it may be too late because you've got it spread all around your body.
Wow.
Yeah. I mean, when you've got a active prostate cancer, depending on where you're treated, they often will, involve that sort of suppression of the androgens, basically. But I think it was 2018, and I think it was the American Endocrinology Association or the Urology Association, but it was Abraham Morgenthaler leading on that. I believe he said that now doctors the guidelines were doctors have to tell patients that there is no evidence to support that testosterone causes prostate cancer, and in fact it may be protective, which is obviously huge when they've reviewed all the evidence, thinking that actually doctors are still, even in this country, like if you grabbed a doctor and most doctors and went, is testosterone good for you, they'd probably say it causes prostate cancer, that because that's drilled into them from that side of things. So when you're, depending on the doctor, I'm sorry to hear about your dad, by the way, that's
okay,
yeah, got that. Sure. Yeah. He, the depending on the doctor that you see in the protocol and the guidelines in the area that you live and all those sorts of things, they may approach it in a certain way, and that can be suppressing androgens, and there's a whole host of things they may do, so it may vary. I know in America there are some doctors that are reducing testosterone during the time of treatment of the cancer, and then are actually giving estrogen to a man whilst they are being treated, because actually estrogen provides a lot of benefits in men, like it does provide mood and sex drive and energy. So it's almost better than just having no testosterone or estrogen. Having the estrogen is and there was some evidence showing that it actually reduced cancerous cells, which blew my mind. And they're actually, in some places, they're looking into that, sort of investigating bipolar androgen therapy, where they're giving men high doses of testosterone when they've got a prostate cancer, high doses of testosterone followed by none, and then high doses again, and then none. I think off the top of my head, something like 400 milligrams at a time, and then stopping. And that was actually helping to fight the cancer in the prostate. So this is where it's sort of heading. But as far as I'm aware, like the majority of places sort of in the UK and things like that, it will involve, trying to remove androgens to a certain extent. There are plenty of people in the world, if they're on TRT and they get prostate cancer, they do maybe come off TRT and they go through the whole rigmarole of what their treatment would be. And then as soon as they're back in remission, they start TRT again and are monitored and doing well, and monitored for any sort of signs of it coming back. So yeah, it may be that it's obviously just what that doctor, I get the argument though that you were saying, but obviously, particularly in the UK or anywhere where you've got a big controlling, like, overarching thing like the NHS, which I think the NHS is great, but it can be, I used to work within it, but it can be a big slow moving sort of ship in terms of like new evidence, because it's got to go through a lot of rigmarole, and it has its benefits, but in terms of finding out new things and implementing things, there's a cost restriction, but also it's just sort of a bit slow to catch up sometimes. Yeah,
which, like you said, it makes sense. In terms of, I know we touched on it earlier, it was going to be one of my later questions, but in infertility, I see that the rates are on the rise, and I know it's not historically accurate, but you watch old films, it seems like people have sex once and they've got, triplets on the way. So, but in the modern era, you got people trying for babies for years and sometimes still not succeeding. It's a very touchy subject. Usually you can't speak about it without evidence or experts. I feel like I've got two here. Is there anything to suggest that maybe TRT treatment or increasing your testosterone does increase your chances of having a baby?
Well, being on TRT treatment will make about 80% of the men infertile whilst they're on treatment. That being said, you don't want to use testosterone treatment as your sole birth control method. So being on TRT is not something that will enhance your fertility. However, there are other additional treatments that you can add, fertility treatments. And so some later studies and fertility clinics used to make men go off the testosterone treatment if they were on it, and then have stimulating selective estrogen receptor modulators that women would also use to induce ovulation. Well, men would take these to improve sperm production, But that was very difficult and painful for men to go from having a very optimal level of testosterone to now having hardly anything or nothing at all for many, many weeks until their own body finally kicked back in and only provides them with an adequate amount, not an optimal amount, gets the sperm production going again. But it's not ideal. So I think in Baylor University, was it, Sam, Dr. Lipschultz did some studies on, having your cake and eating it. Essentially, a man doesn't have to go off his testosterone treatment. He can maybe slightly lower it or stay on the same treatment and then add in something called HCG and occasionally a SERM called clomiphene used concurrently together to both maintain his libido through the exogenous testosterone, but also improve the intratesticular testosterone in his testes. Because I guess the irony of it is, you can have all this testosterone circulating in your body from the injections or the creams, but your testes is where it matters. The origination, when the testosterone is created within in the testicular tissue, that's what helps drive the fertility. But just because you've got floating around in your body from an injection doesn't necessarily, and in fact, it has a negative impact on fertility.
Oh, wow.
Yeah.
I wouldn't have thought that. That's cool.
Yes, it's one of those things. It's something that, men are educated in, that TRT, one of the side effects is that it can reduce sperm count. And that's basically because if you're getting a supply of testosterone that's not from your testicles, the normal sort of feedback loop, very basically, the brain detects if there's enough testosterone in the body, essentially, very basically, and then it will send out a signal to the testicles to tell it to make testosterone and sperm. And then if you get the supply of testosterone, not from the testicles, but from somewhere else, the brain is just doing its job and goes, yep, got plenty of testosterone, so I don't need to send the signal to the testicles to make testosterone and sperm. So sperm production and testosterone production from the testicles would be suppressed when you're on TRT. And it's like having you've got a thermostat in a house, and it's set at a certain temperature. When the thermostat detects as a temperature drop, tells the boiler to turn on to make some more heat, reaches a certain heat, the signal from the thermostat switches off, and then you're keeping the temperature regulation. But then, like, TRT is like putting an electric heater in the house. There's another supply of testosterone, and the thermostat's just doing its job and testing that there's enough testosterone. So it just won't send any signal to the boiler because there's plenty of heat. But turns out, that boiler, which is like our testicles, also makes sperm. So that's why you end up with a suppression of testosterone production, and sperm count can go down. But like Mike just explained, there is an option to stimulate the testicles to create sperm again whilst you're on TRT, which is called HCG.
Does that work in a similar effect to the way steroids work, where let's say they have what's called a half-life, which you're probably aware of, where let's say you take them for a year, and then it will once you get off them, it might take 6 months. It's usually half of how long you've been taking them. So 6 months to get your natural production of testosterone going again. Is it similar without the side effects, of course?
So steroids, testosterone, sometimes they get mixed interchangeably because the backbone of the organic molecule is a steroid ring. And, some from the control point of view, from the government, may lump testosterone in as a controlled substance, as it is in most countries. The premise that you're talking about, though, the time for recovery after being on either exogenous hormones or testosterone, and I'll just go through the difference between what's the difference between testosterone and steroids, is that testosterone mimics or is identical to what your body makes. Okay, and it comes in different formats. So you can have testosterone as a raw, natural, bioidentical testosterone that your body makes, and it has to get into the body. Usually, can be through a cream or a gel applied either on your skin, on your chest, or under your arms, or on your scrotum if it's a cream. And injectable testosterone is tied to a fatty acid ester, sometimes found naturally in the body, sometimes not, which the body enzymatically, through enzymes in the body, it cleaves off this chain, this fatty acid chain, which slows its release in the body, and giving what the free-floating natural bioidentical testosterone. So they both kind of do the same thing. An anabolic steroid looks similar in the molecular structure to testosterone, but it's not. It's tweaked. There might be like an oxygen group or hydrogen group within the organic structure causing it to bind differently to the androgen receptor, because that's what all these hormones do. They bind to a receptor and activate some sort of cellular response. So this is the difference between the two. One is identical to what the body makes, and the other is a synthetic version of testosterone. Okay, and any of these will suppress your natural production of testosterone over time. And I think the rule of thumb is usually twice the length of time off these suppressing hormones as you were on them to get a full recovery. But and most people have a full recovery, but recovery to what? To a normal level, or then do you get stuck to having a inadequate amount compared to what you were used to? Because the body can change its response to how well you feel on a certain level of testosterone. So some guys who were normal before may return to being normal, but they don't feel normal once they've returned to that level because of how they felt in the past.
I think that's it, isn't it? It's important to note that when you hear of steroid use, when someone is abusing an anabolic steroid, or sometimes they even abuse testosterone too, that they're people with functioning systems that produce testosterone that want to take large amounts of these things for physical changes, usually athletic performance enhancing, and they want to take it for a period of time, a length of time that's long enough where they get the benefits but the side effects aren't too bad. And what they want to do is they then want to try and get their own body's production back, which is the bit where they stop. Then they're trying to get their body back online. And that's the difference, is it? That time, there isn't a set time on, time off. Some people advise it, but you can be on, a bunch of anabolic steroids, for example, and your suppression may be more in one person than another. And the time it takes for your system to come back may be slower than another. Age, obviously, function of the body, how it was functioning before. I mean, some guys head towards that side of things because they've got symptoms of low testosterone, and they gravitate towards things like androgens, and they hear about these things and people having better sex drive and better recovery. So they actually end up, maybe they had a testosterone deficiency to begin with. So when they come off the anabolics, they weren't working very well, first of all, and now it's worse than before it started. But that is important, that Mike said, is that the anabolic steroids, testosterone was what they isolated, and then it was for medicine over the years. I mean, testosterone's got an androgenic to an anabolic ratio of like 100 to 100, and means it has an androgen effect in the body, the masculinizing features, all those sorts of things and effects that men need alongside a sort of tissue repair building sort of anabolic ratio. And their aim through taking testosterone and then chemically altering it, like Mike said, was to try and improve that ratio so that they could give these new anabolic steroids to women, to children, to people around surgery, to enhance healing, to enhance recovery. A few other sort of applications for them, like improving red blood cell count and things like that in anemia. But that's what they were trying to do. But then obviously athletes were like, well, I can take something that's like testosterone, but it's got an anabolic ratio of a massive anabolic effect to like a lower androgenic effect. I'm going to abuse those. And that's sort of how it came about, is you've got anabolic steroids, which were chemically altered versions of testosterone and some of the other derivatives of testosterone. So it's clear, it's good. It's important to make that, that sort of distinction between them.
That's good.
Go ahead.
Yeah. That's a good point, Sam, because, and I think the part that you mentioned about certain men who gravitate towards, seeking these treatments, they might be in the gym seeing their mates who might not be on anything, but they suspect they are. And because they respond very well to certain activities, diet, exercise, and the other guy doesn't. And he, like you said, he has these other symptoms of sexual dysfunction potential, not as good as his mates are. And so he seeks it out, just like some people, if they don't discover, our services, they'll order a blood test because their GP refused it. And then, unfortunately, they'll end up trying to self-medicate because they have nowhere to turn to, or they haven't discovered the other options. And it's because they're seeking answers, to this problem that's not really being addressed by the NHS.
So I've forgotten the question, but we got way off topic there. What was the
difference between?
It's okay. I quite I quite like it when it goes off topic. It means it's an organic discussion. So it's hard. I kind of get lost in the discussion myself. It's hard to monitor everything, think of the questions, and listen to what you guys are saying. So
that's cool. Yeah, stop us if we're rambling. Yeah.
I was going to ask about, because you touched on a few things there where you said it seems as though there's a lot of things that are environmental that are affecting us, but it also seems as though there's definitely a part that genetics are playing. What would you say the kind of split percentage is between the two?
That's difficult. I mean, there's so many factors that potentially could be.
Or is it the environment affecting the epigenetics?
Yeah.
So you've got your blueprint, your genes, but then you've got the instruction guide of how to make that. So, and if that gets upset or disrupted, could that be one reason for? And it could be the environmental toxins affecting the epigenome. So, yeah, I couldn't give you a percentage. I don't know. I mean, what we see are we get the men. And sometimes women, because women can have low testosterone as well, they come in, to the clinic or contact us and, have these concerns, and then we have to address them the best way.
I think that's it. Is that there's no way of knowing whether this is your genetics 100%, whether it's epigenetic, whether it's environmental. There's things like trauma, psychological or physical trauma, or during childhood, and maybe deficiencies at certain points, right back to the womb. There's so many factors that are in play. But I think it's obviously when you get to that point of having symptoms, potentially needing treatment, you obviously take it. The doctors have got to take it by a case basis and sort of treat what's in front of them. So yeah, I think it'd be hard to get. I mean, there's definitely genetic factors. There are genetic conditions that are associated, with low testosterone, hemochromatosis, some chromosomal conditions, autoimmune disease, things like that. And then, there's the environment, and it's just got to be a mix of both, right? To end up, do you agree, Mike?
Yeah, I agree. I mean, even with the autoimmune disorders, it could be, if you're allergic to wheat, celiac, potentially that could be causing a flare-up, and that's more for thyroid. But who's to know what other effects of that autoimmune are on your testes? If your body's inflamed, one organ could be inflamed in the other.
Yeah.
So you said epigenetics, which really caught my attention. I've always said, guys don't realize that what they're doing now and how they're living now is affecting how their kids are going to be in the future. And I believe epigenetics is going to explode. I mean, it's already taken off, but I think it's going to explode in terms of showing people why certain things have happened to them in their lives, or, how it's been passed on. And I think it might take the percentage of discussions that genetics alone has been taking. It's going to take responsibility for them in the future. With things getting worse, as we said earlier, the testosterone levels are a third as what they were, let's say, 100 years ago. Let's say this trend continues. Are we looking at a situation, I don't know if you've seen the film, but would be similar to something like Children of Men, where the entire planet goes, you've seen the film, that's okay then.
Yeah, I like that film.
Yeah, great film. Yeah.
That's a good film. I don't know. We lost down to the last one, and then a new child's born under this new.
Yeah.
I hope not. I think that'd be terrible to still be in the future. Yeah. But I think there are ways that with technology, worst case scenario, it would just make it more expensive for people to have children. You have to have more IVF, you'd have to have more intervention, and that might not be for everyone. So there may be a big divide between those who can afford it and those who can't if it's not provided on the NHS, so it might be out of the budget for the NHS. So because obviously that would be more on a national level kind of part of the country strategy. If you're losing population, that's not going to be really good for the economy, for anything.
Yeah, I think it's. Sorry, Mike. Just going to say, it's one of those things where I think if it's being recognised as an issue, there's got to be some massive recognition of it and act upon it in some way. It's got to be. But look at pollution, global warming, things like that. The environment there's plenty of people sort of campaigning for it and pushing it, but I don't know how much of an influence they're having. But that could equally, be as detrimental to our lifespan, and the fact that men's fertility levels are dropping already, finding out what is the cause or what potentially could be the cause, and then taking on a mass scale to sort of try and, remove those factors is probably where it needs to go, I think. But it's time's going to tell, isn't it? It's going to be the trend. I mean, I know the ginger gene's dying out, so I've got to try and keep that one strong for as long as I can. So yeah, lots of HCG for me. But yeah, I think that's my view on it, Mike. I don't know, sorry, I cut you off.
I think we can just chip away. I guess I'm more of a rugged individual in some regards, in the sense that, we can't always depend on a big government program to solve all these problems. And where we can, on the ground level, help to make things better, that's what we're trying to do. That's why I set this up. I couldn't depend on the NHS to change their policy towards men with low testosterone. So, I set up Balance My Hormones so we can find solutions for people who weren't getting the help that they needed. And that's all we can do, is hope that there are interventions. And if there's enough people on a larger scale that could come together, it might happen. But like Sam said, look at the environmental movement. It's just very slow and incremental, the changes. And, this has been going on for 30, 40 years. You don't see a massive change. We're still using fossil fuels. There's still, pollution. The oceans are getting worse with the toxic plastics, which we then eat through fish or fish oils. And it's doesn't seem to be getting any better on so many fronts. So if we can do our bit, our part in the TRT world, but in some ways we're fighting fire with fire, right? Ideally, the body would make more of its own. We would find some sort of genetic or some therapy that would instruct the body to make more. But the least invasive, probably most cost-effective method would be some sort of exogenous testosterone treatment. Either some topical scrotal cream or injectables if it works for most men. And when fertility is required, it might require a few more treatments added to the mix, or there may be testosterone boosting treatments if you've never been on an exogenous testosterone. So there are ways that can help today men that have low levels, and hopefully with an eye towards the future, if the environment cleans up, maybe men generations from now might not need testosterone, or maybe we get so many men on testosterone treatment that it changes the epigenome, where then the body requires more testosterone. So either it has to kick in, make more, or we're always on testosterone. I'm not really sure.
Yeah.
One thing I really wanted to ask you again, well, both of you, but specifically Mike, is when we spoke the other day about the receptors in the body and how, I think it was pollution, how that's affected the receptors. I think you said that you can have all the testosterone in the world, but if the receptors get affected, it means nothing. That blew my mind.
Yeah, there's certain endocrine disruptors that don't just disrupt the pituitary axis for the production of testosterone. I think this is also in that book, the Anthony J, about estrogen. What's it called? Estrogenation, Sam?
It's like how the Americans say estrogen, so it's like estrogeneration.
Estrogeneration. And so there's a certain type of this chemical endocrine disruptor that actually attaches to the receptor, blocking the entry of the testosterone or the androgen into the receptor. And so you could have lots of floating around, but you've induced a state of, what's it called? Androgen insensitivity syndrome. Or some people, there's a genetic component where you test their blood, they've got a massively high amount of gonadotropins, LH and FSH, that's like part of the thermostat, and they get massive amounts of testosterone, but they have feminized genitals, or very small genitals as a result, because they've got this genetic abnormality which causes the body not to either make dihydrotestosterone or receive the dihydrotestosterone if it does make it. So that's, in some ways, it may be what some people might be having created as a result of exposure to these chemicals.
This is the other argument in America, sort of the sort of leaders in the field where they're able to be a bit more liberal with how they treat, is that their argument is thyroid sort of insensitivity, thyroid resistance was something that they fought for in the medical community for a while, which was you may need larger amounts of thyroid hormone to actually exert an effect in the body that the body needs because of insensitivity to receptors being blocked. And just like with insulin insensitivity, where diabetics need more and more and more often, to actually have the same effect for insulin to control blood sugar. That hormone is needed to control blood sugar. Thyroid hormone is the same. So with all of these known endocrine disrupting chemicals blocking the androgen receptor, why can I? This is their argument is, why can I not give a man who's got good levels of testosterone more testosterone if they've got symptoms? Because they could have great blood levels of testosterone, but they could have, like Mike said, all of those receptors blocked, not allowing them to exert their effects. And by increasing the amount of testosterone, sometimes way above what, in a blood test you might see as physiological, to actually get symptomatic resolution, get the actual actions of testosterone in the body, why can they not do that? So that's why they, and using the argument of there's no evidence to show it's a certain level either, that testosterone levels, symptoms begin to appear at a certain testosterone level. Why can I not just give a man who's got good levels of testosterone more to see if it improves his symptoms, his blood work and things like that?
So there was androgen sensitivity syndrome that I've seen in some of the NHS's NICE guidelines. And one of them was, for those particular subset of patients, they will give what they consider a massively high dose. So they may give 250 milligrams of testosterone per week for those patients to get enough, but that's really the only treatment. And ideally would probably also have like a DHT component as well, but that's not available commercially. So they recognize that for those it's a very rare amount of people, a very small amount of people that would have that particular genetic defect. But so that it's already kind of established. But you're right, Sam, in other people that might not have been identified because of environmental factors. We see that some patients require more testosterone than others to resolve the symptoms.
There's a common kind of thought out there right now, especially in kind of the sporting world, that I guess a lot of weightlifters too, but as soon as you get to around about 40, a lot of people saying if you've got enough money, you should get on TRT. Is there kind of a recommended age, or is it very case by case?
I think it's case by case. I don't think you can say if you're 40 years old and you've got a really good functioning pituitary axis and you don't really have symptoms other than the desire to be really muscly, but if you've got the libido, the morning erections, good amount of energy, get up and go, and you don't seem to have the other problems, then it's kind of a waste to do that. But you can keep an eye on if things start degrading, or you can get a blood test and you can take that blood test and say, wow, I'm 40 years old. I've got these massively optimal levels at 40. And you can hang it on the wall, be proud of it. And then if you start getting symptoms 5 years later, 6 years later, then you get another blood test and then you've got something to compare it with. And now you know what your optimal level was, at least at that point at 40. And when it goes downhill from there, you'll know, and maybe you've got that evidence to show your doctor to say, well, I was here at 40. I got these symptoms now and I'm 45. Clearly, maybe there is a need to be on treatment.
Yeah.
So I'm a big advocate for testing. I think, even adolescents should be tested because so many of the problems can come at a younger age, and no one routinely tests this as part of your workup. And, there's psychological issues. There's issues of not entering puberty at the same rate as your peers. Sometimes it's not just delayed puberty, but it could also be the fact that you're hypogonadal, but in an adolescent state. And then you'll continue to be throughout the rest of your life. So if this were part of the general screening, I think you may solve a lot of problems earlier on. And if you end up being on testosterone anyway, how nice would it have been to know if you started it earlier that your quality of life would have been better from an earlier age on. Yes, you've got to be on a medication. That's not always perfect for everyone. And traditionally, everyone thinks, if you don't have to be on any medications, that's preferred. And that is, it makes life a bit simpler. But if you've got these symptoms lingering for decades that affects relationships and your quality of life, then I think there's an argument to be made for starting, or at least monitoring, screening people at a younger age. Like
thyroid issues, for example, are picked up in younger people, obviously there's in things like the NHS, there's obviously restrictions. Everyone's not just tested for everything every year, but starting in some insurance companies and things, they are figuring out that if they test people earlier on for things like hormone deficiencies, it's probably going to save the money in the long term of other health conditions. But the thyroid is detected early on, so I think, like Mike said, adolescents and things, they do it now. So if someone presents with particularly underdeveloped characteristics and they do the genetics testing and things like that, but we've had a few guys that actually they said, oh, for about 6 months when I was like 15 or 16, I got put on testosterone by the NHS just for that period of time because they said I was underdeveloped. So they had low testosterone, they got put on testosterone for 6 months, and then they've come off, and obviously they were suppressed during that time, and then they've got low testosterone again. And it can be like their late 20s, early 30s, but they've lived for the last decade with, on antidepressant medication, anti-anxiety medication, lack of sexual activity, all those things. So it is sort of picked up, but it should be screened, like Mike said. It should have been looked at throughout the journey. And I think that, going back to your question, I don't think if you're at 40, if you're at 50, if you're 60 and you've got good levels and you don't have symptoms, I don't think there's any reason to at all. I've chatted to some like 55-year-olds that are like, they've got higher levels naturally than I've got on TRT. And they're just like, they laugh about it. They were just coming to get a blood test for like a baseline. They're like, I just want to keep an eye on this, which is what Mike said. I think it's a sensible thing to do. Have that baseline, and if it changes, then you can compare. But I think at any age, if you have symptoms, like I said before, it's a box to definitely tick. I think you need to have it looked into, monitored, because there are some other options. There may be other conditions, other factors, diet, lifestyle, things like that, a young age or something going on that may be contributing. So keeping an eye on the hormones and where they're at, and if you correct all those other things, and then there's still that way to go, then you can consider sort of getting an intervention, I suppose, with a doctor and to try and correct your hormones.
I think even vitamin D3 monitoring is very important because that really is more than a vitamin. It actually acts like a hormone in the body. So that's very important to monitor it, and throughout life, really.
Don't get much sun, do we?
No.
Ginger people can absorb a little bit more, I think, though. That's one blessing for us.
Like solar panels.
Yeah.
So with all that being said, what the hell is Mike Tyson doing? How is he 6 months ago, in the worst shape of his life, dad bods, looking like he's on the decline. 6 months later, at 53 years old, he's in the best shape of his life, moving like he was when he was 21. Is that, and he's hanging out, like we said, with TRT Belfort. So is it likely that he's on TRT, or is he just a freak?
Well, I know people are just going to jump into being like, it's got to be TRT, it's got to be anabolic steroid use. Yeah. And it may be that, but he's got money, right? He's got amazing genetic. This is my view on it. I'm happy someone tells me that they think I'm wrong, but he's got amazing genetic. Look at him as an athlete. He was like, I think when he was like 16 or 15 years old, he looked like he was like a 35-year-old man. Like, he was an absolute unit. And he's look at what he's achieved, look what he can do. So he's probably got a strong genetic foundation. I think we probably agree on that. That he's got that underneath. He's probably got loads of money to get his diet bang on. He's probably got someone covering his nutrition, someone covering his training, sleep, all those sorts of things. Yeah, you're right. The age, I doubt he might be on TRT already. And if you've got those optimized hormone levels, if you do all those right things and you've got the genetics, I mean, you can see some real. We got some guys like in their 50s who are just, some of them are like amateur boxers now, doing like amazingly well, like absolutely in like a shape that I've never ever been in, like ever in my life. And I don't know how they got to there. And they're on TRT. They're doing all the right things. So I think maybe he's on TRT. Obviously, look, in America, celebrities, they have access to it. And particularly in America, it's been around a lot longer, right, Mike?
Yeah. Well, it has and it hasn't. So, I mean, even in America, I know we look to America from here and say, they've got all these things available, and they do. But also Americans, like with their NHS here, feel like they're kind of chained to their insurance plan. And a lot of the insurance plans, they're out to make money, and they don't want to pay for the treatments if they don't have to. So when I was at the Arnold Classic in Columbus this year, one of the doctors in Columbus said, he's got to tell his patients, to come off testosterone for about 2 weeks so they can get a new baseline level every 6 months, which is insane to have to come off your testosterone just so they can qualify and get coverage from their healthcare insurance. So So it's not, if you expect to have someone else pay for your healthcare, you have to jump through those hoops, just like we do with the NHS. And if you're willing to pay cash pay in America, there are doctors who don't have the constraints like we do here through their regulatory bodies to the same degree we have here, who are able to trial new therapies based on evidence to enhance one's quality of life and to, and solve the problems with the symptoms. And so that's just want to let people know that, America, land of the free, home of the brave, and TRT, yes and no. It might not have TRT as readily available as you think, depending on your resource and your ability to pay for it.
Probably misinformation for me. Like it absolutely is. When I've been referring to America in this whole conversation, it's essentially the cash-based doctors that specialize in this that can do it. I know Mike knows, but they probably think that you can just pop over to America and walk into any hospital and it will happen.
If you're in the Veterans Administration, because you're a vet, which is, I would say, comparable to our NHS, but not, I would say, it's not as, I can't even compare it to the NHS, because the NHS is, amazing, the level of service overall that you get for general things. But both being governmentally run programs, they're very restrictive, the VA, from what I've heard of people that I know in the States, even more so than the private health insurance that's available. So they're going to look at it very much in this governmental, institutional, one-size-fits-all approach, like our NHS does for the most part for men's TRT.
But yeah, I think Mike Tyson's probably got some money and probably can see a private doctor. So maybe that's my point. Maybe that's.
And you know what? There should be no problem with it. There should be no shame. If he had a suboptimal level as a man, and this is enhancing his life, and he also does something that he loves, and he's only getting his levels to an optimal level for him, there's no disadvantage. Especially, if anything, the disadvantage is his age.
Yeah, 100%. Look, he's been smoking a lot of weed as well. I think he's heavily invested in the cannabis industry, and I think that he enjoys that, and he's been doing that for a long period of time, and that. And maybe eating a bit more, being less active, and things like that. It may be that he's, whatever it is, he's, having this is the thing about TRT. There are plenty of people out there that have great testosterone levels who are unfit, fat, having insulin insensitivity. It's not a magic bullet, but if you're doing all of the right things and you've got optimal testosterone levels, whether that's a nice natural level that's produced, consistently, nice healthy level from your own body, or whether it's TRT, if you start doing those other things, training, diet, sleep, mental health work, mindfulness, all those things, self, improvement, that's when all of it comes together. And if you remove the hormones from all of those activities, you might make improvements, and fair enough, but it's definitely hindered. Would you agree, Mike?
Yeah, definitely. Yeah. Like what my one mate say, testosterone and donuts don't mix. Psychiatrist. You have to do the right things. You can't expect testosterone to do all the heavy lifting. But like you said, we've seen guys who were doing all the right things: diet, exercise, proper sleep, mindfulness, and then we're still low on testosterone. And started the testosterone treatment, and they just blossomed. Everything came together. It all seemed to work as it should. And that's an amazing success story on their part.
Yeah, which is when I was mentioning, if you've got symptoms, you've got to tick the boxes, right? So, and I think some of those things, all of those things are things that have to be considered. If you're stressed, if you've got low mood, you're fatigued, tick the testosterone box. So absolutely. And I think it's a great place to look into, start investigating. You may not even deal with that immediately. You may go, right, well, I'm clearly not sleeping. I don't sleep at all. I sleep an hour a night. I'm going to try and nail some of that first and see if I can improve those other areas: diet, exercise, mindfulness. Do those things, and then maybe check in on the testosterone again, and use it all as a whole picture. And if you get TRT and that's something you actually start receiving, then you got it. And that's when guys actually, it's a big part on TRT. We talk about the journey through it, where some guys think that just taking testosterone is going to magically puppet them up, make them go and do mindfulness, make them go and train, and suddenly achieve 10 years worth of training in the gym, as a base, and able to make them sleep perfectly, and they won't get disrupted, and they won't go on their phone, and then it's going to make them do it. And it's absolutely not the case. Is if you have the hormones in the right place and then you start to do them, that's when you get the compounded reassurance and sort of a reminder of what having optimal testosterone allows you to do if you do the right things, if that's a good summary.
That makes sense, yeah. And you have to assume as well, Tyson's been there, he's done it. He's like his level of training is probably like 10, 20, 30 times harder, longer than any of us could ever imagine. Like he's been there, he's done it at the top level. The one thing that I wanted to ask you guys is probably the final question before I direct it to where people can find you. But what's the link between fasting? I've heard that there's like some reported cases of if you fast for 24 hours, your HGH can go through the roof. Is that true?
Yeah, Mike?
Yeah, there is something when you fast, you can get elevations, but any of these interventions are short-lived. So they say if you do squats, you're going to boost your testosterone level as well, or if you eat this or that, you're going to get this boost. And I mean, you can't go around your whole life fasting just to get that growth hormone boost, and you can't do squats all the time just to get the testosterone release. So look, there are certain interventions they do to test your growth hormone as a growth hormone stimulation test, where they'll intravenously inject arginine, or they'll have some sort of growth hormone releasing hormone to test your output of your growth hormone so you can actually measure that. And so there are interventions that you can take, but those are called diagnostics. Those aren't necessarily your full-time treatment if you are deficient in one of those. So I don't know. I don't know enough about it. I do remember this. Some fasting, you can get higher levels. I know when we have people do their blood tests, we ask them to fast, mostly so that we would get a proper look at the lipid levels, making sure the triglycerides are low enough. And in our normal panels, most men we have to do a special test for IGF-1, which is a measure of the function of growth hormone. So growth hormone is very pulsatile in nature, and you're not going to just be able to randomly go get that test at this time unless there's some sort of stimulus. And fasting isn't normally one of the stimuluses that are used by the laboratory to measure your growth hormone. Okay, so it's usually some other sort of drug. I think sermorelin is a growth hormone releasing type hormone that's used as a diagnostic to test your function of growth hormone if it's suspected that you've got a growth hormone deficiency. And then if you're put on treatment, it's usually human growth hormone after that. But generally for clients that we're looking to see what the function of the human growth hormone level is, you can measure something called insulin-like growth factor 1. And insulin-like growth factor 1 is a good determinant because it sticks around in the blood a lot longer. So growth hormone, the way it works is it gets secreted from the brain, the liver converts it into IGF-1, and then if you measure the IGF-1 levels, you then have a better understanding of how much growth hormone's in the body.
Okay. I think it's that part as well, in the presence of low insulin. So obviously when you eat food or carbs or things, if you get an insulin release, I think it blunts that IGF-1 conversion in the liver from your growth hormone. So optimal growth hormone, like if people are using growth hormone exogenously in any sort of circumstance, or even like the peptides, often using it in a fasted state helps with that growth factor production. There's other things as well, like estrogen's needed and things to optimize that. But I think fasting's just it's not for everybody, if you've got adrenal issues or thyroid issues. And I found out the hard way with that I was trying to intermittent fast whilst trying to recover my thyroid and ended up with really poor blood sugar control. But if you're fasting, I think it's a good thing to do. You can do intermittent fasting if you're healthy and you're trying to lose weight, improve your insulin sensitivity. I think it's a healthy thing to do. And obviously if your growth hormone release is optimized during that time, then that's a win as well.
I mean, I do intermittent fasting. It's usually called skipping breakfast. Feel so guilty about like, oh, I didn't really skip breakfast today. I just did intermittent fasting.
Yeah.
That's, but it's, I think there's a place for it. I think you have to also be careful that you don't double down on your calories for that particular day, because it's very easy to do if you do skip a meal, which is why, in the early noughties, I was very big into the 5 or 6 meals a day, small, frequent meals throughout the day. And I seemed like I was at my leanest at that point, but it's very hard to do. to take a break, to stop, or prepare your meals. So I guess just whatever works for most people. And I think there can be some benefit for intermittent fasting. I've tried it myself.
Okay, there's so much information here that we've covered. I mean, I'm going to be able to put out about 100 snippets out of this. So unbelievable stuff. If people wanted to get in contact with you guys, how would they do that? Where can they find you? And also, what's the kind of process, maybe costs that they can expect if they want to go down this route?
Okay. So you can find us at balancemyhormones.co.uk is the website. And, we're a full service. There's different bits to our service. The initial bit is your blood testing service, which is self-service, or you can call the office and we can organize the blood test for you. You can order directly from the website, for hours that we're not in the office. So the one way to contact us is through the main number, +44 or 020-3900-3209. Or you can contact us on the website directly. We've got an online chat feature, which features our own staff, that are answering that online chat. It's not a robot or AI, or someone in another country. It's actual employees of ours in the UK that are answering questions that have good knowledge of how to direct you. The other part of the company, of course, is the clinic that we offer. The clinic services for treatment of low T, and we also have the network of doctors around the UK as well. So, but it starts with a blood test, and our blood test, compared to other services out there, will actually direct the patient to the most efficient way to treatment. So, a cost of a blood test can start at £44 for you. And we don't sell just the testosterone total on its own, because that's kind of meaningless. Just having the total, as we said earlier, we need to know what the binding hormone is, the sex hormone binding globulin. We need to know what your calculated free testosterone is to get a better picture, at least if you're just curious about your testosterone. So I think we sell the test for I think a lower price compared to other companies that will sell just a testosterone test. We try to give you the testosterone plus is what the test is called. And the secondary test, there's two other tests that we will aim you towards. It's a mini comprehensive one that looks at just enough for like hematology, full blood count, cholesterol levels, testosterone, estrogen, luteinizing hormone. They're on the website, and that test is about £79. So the general range is $44.95 up to about $155 for our most comprehensive test that looks at a whole load of things like vitamins, as well as a full blood count and everything you need for TRT. So all the tests are directed, one, if you're curious, and two, to help you get on treatment, once you've satisfied your curiosity and you find out that you might be low. And our staff is there for full support and the coaching, for that part of it. And then obviously if you do get on treatment, Sam could tell you about the other part of the service, that could vary depending on which treatment that you require. It could be anything from testosterone boosting with certain fertility medications, all the way up to testicular scrotal application of creams, to certain injectable testosterone that may be needed. And there's obviously a cost for the doctor's consultation, and as well as the medication. Sam, do you want to?
Yeah, we've got a good, the best, obviously, the treatments are bespoke. It's not just one thing for one person. If you go on the website, we've got a summary of costs on there, a whole page on it. So it's probably better people just run through that and you can see them on there. So it's pretty easy to see.
As well, for the blood test part, there is as well. So, I think one of the things that we work through the process is to make sure that you're supported every step of the way. You essentially, you get your TRT coach that's there to support and guide you throughout the process. Even when you come in for a blood test, if you have questions, we're there. As people who have been on the treatment, we've got a staff that, the ones that are interfacing in the coaching service, that have been on the treatment or, previously as a medical doctor, helping men and women kind of sort out their hormones and experience the support throughout the whole process.
It's from start. So from even when you come in, it's just from start all the way through. We're sort of with you. I don't want to say holding your hand, but it's essentially got someone who's been through it that you can speak to whenever you need to. You can make an appointment. It's sort of all included in our sort of subscription of the treatment plan that you're on. So, and we stay with you along the way. So I've got a certain number of men that, you know, I deal with and support through the journey. And if you come through, you'll have somebody to sort of, you know, it's answering stupid questions that, you know, you may not want to bother the doctor with, or may not want to have another consultation with, like, you know, I'm at 6 weeks, you know, what do men normally experience at 6 weeks? Is it normal that men normally feel this? And it might be that actually the answer might be as different for different people, but this might improve at this point. And so we're there along the way for that sort of informal, non-medical stuff. Obviously, you have your doctor that you have your consultations with, and you can have consultations with along the way. But yeah, it's that sort of that personal coach side of things that guys find really helpful. I mean, when I came through, I had anxieties. I mean, even, you know, someone mentions about it, there's usually questions like, you know, how often will I need to do this? What's it going to be like if you suddenly feel strange or weird, or this is the classic thing, is there's a lot of misinformation or utilization of information about TRT and social media by certain people and doctors and things to sort of make people gravitate towards them. You know, it's create an anxiety about something, then give the person the answer to the anxiety, which is to come and see me. And it really does affect people. It affected me early on in TRT. I thought I should be on this dose, a certain frequency, this, that, and the other. So just to have a certain point of contact of actually knowing a big patient cohort of what they go through is usually really helpful, just to separate sort of the wheat from the chaff, you know, on the internet, because you can read something, right, and it can terrify you.
Yeah, it can be a minefield out there for some of these guys. I mean, we talked to some of them that, you know, you find out, they said, oh, well, you know, I thought about this, I heard about this online, you know, wanted to try that. And you've got to really support them to say, you know, stay the course for what the doctor chose, because it's very easy to go down into the weeds with, because you heard this and you heard that. And that might be applicable to someone who has a particular almost phenotype of it, you know, they might have certain blood panel. That might be the best treatment for them. But really, the best treatment for a patient is a treatment that's going to work best for that patient. And you can't compare what your treatment is necessarily to someone else's treatment. And the doctor creates a treatment plan, a bespoke treatment plan, you know, for that patient situation, based on the blood profiles and based on you know, their experience.
Perfect, guys. So much information there. I can't wait to actually watch it back so that I can, you know, I can listen properly as a fan rather than somebody who's just asking the questions, should I say?
Well, good.
I think we're going to end it there. But thank you so much for coming on, guys. Really, really appreciate your time, and I think we're going to help thousands of men with this video. So it's great.
Good, thanks. Well, we'd like to have you on our channel as well. We've got a YouTube channel. We're kind of growing the base. About 1,230 at the moment. So just Balance My Hormones is another place where they get more information, and we'll have you on there too.
That would be great. Thank you so much. Really appreciate it, guys.
Cheers, mate. Yeah, thank you.
Speak to you soon. See you guys.
Cheers.
Bye.